Hi everyone, welcome back to the YouTube session of the Microbiology Crash Course. For all of those who are new out here, I'm Dr. Preeti Sharma and I am an educator for pathology and microbiology. Well, we are continuing with the Microbio Crash Course for the upcoming NEET, NEXT and FMG exam students, and we've already completed 4-5 essential components of this particular crash course. We finished with 2 parts of general microbiology, we finished with a very important section that is fungus or mycology, and we've also finished a portion of bacteriology. Today we'll be taking the bacteriology forward and dealing with the other bacteria that come under it. So for all of those who've probably missed out on the previous videos, they are available on the platform. They are available under the video section. There's a separate playlist that is there, so all of you can certainly look at all the microbiology videos from there. Also, as with regard to the PDF of this particular, all these classes that are going on, the PDFs of these will be available on the Telegram group. I've put the link to the Telegram group in the description below. The Telegram channel and the group, the description below has the name. It goes by the name of Pathology by Dr. Preeti Sharma. So you can follow me on the Telegram or Instagram or Facebook groups and you would be able to download the PDF from Telegram and Facebook. Well, having said that, let's begin with the bacteria, and the set of bacteria that we have to cover today become the spore forming bacteria. When I say spore forming bacteria, the ones which make spores, there are two that come under it. One is going to be Bacillus. Bacillus, having the A immediate to it, is an aerobe. It requires oxygen. And Clostridium is claustrophobic, means less oxygen. So Clostridium happens to be an anaerobe. So please remember, first and foremost, Bacillus, A, so it's an aerobe, and Clostridium reminds us of claustrophobic, so that is an anaerobe. So let's begin with the very first question and then we'll study accordingly. Question number 1 out here, guys. Which of the following is not a virulence factor of Bacillus anthracis? Which of the following is not a virulence factor? Labile toxin, edema toxin, lethal toxin, or capsular polysaccharide? And the correct answer to this is labile toxin is not a virulence factor. So you would obviously ask me, what are the virulence factors that are there for Bacillus anthracis? So remember, Bacillus anthrax, that you commonly know it as, it has two things. Number one, it has a capsule, and number two, it has a toxin. Both of them are responsible for its virulence. Now, I think when we were studying the first part of general microbiology, we studied that all capsules are made up of polysaccharides. I think that's a very famous thing that we studied. All capsules are made up of polysaccharides except Bacillus anthracis. That is where it comes across as an exception, except Bacillus anthracis, where the capsule is made up of polypeptide. Other than that, all other capsules in the subject with all the bacteria, they are made up of polysaccharides. What about the toxin? The toxin has 3 parts to it, which you call as the EPL. So remember, many students learn it as the English Premier League. So if you wish to learn it that way. What is EPL? 3 parts of the toxin. So remember, EPL have to work together. EPL have to work as a combination. Only then the toxin is going to make its activity. So what is EPL? E for edema factor, P for protective factor, and L for lethal factor. So E for edema factor, edema means how does it cause edema? By increasing the cyclic AMP. It causes edema, it makes sure that the bacteria is protected, it makes sure that it can cause killing, it can cause destruction, that is lethal. Remember, edema, protective, lethal. EPL are the 3 factors. Now when I come back to the question, which of the following is not a virulence factor? So is the capsule a virulence factor? Yes. And what is the capsule of Bacillus anthracis made up of? It is made up of polypeptide. It is that exception. So it is a virulence factor. Other than that, EPL are virulence factors. So E for edema toxin, P for protective toxin, and L for lethal toxin. Basically, there is nothing known as a labile toxin, and that was the question that you had. Now that you've understood everything about anthracis, why don't we study all the other things associated with it? How many types of anthrax are known? Very easy. Once you know this, you will be able to answer a lot of questions. There are 3 types of anthrax that we have. The anthrax affecting the skin, so I call it cutaneous. Anthrax affecting the lungs, so I call it pulmonary anthrax. And anthrax affecting the intestine, so we call it intestinal anthrax. Simple. Cutaneous, pulmonary, intestine. So how do these happen? How does the bacteria enter our body? How does it cause skin and lung and intestine involvement? So for skin, remember, we call it Hyde-Potter's disease. Have you all seen the workers who carry animal skin? I'll show you a picture. Have you seen that whenever the workers carry animal skin, they always carry it on their neck and on their shoulders, so as if they are carrying a rug, as if they are carrying a bag, right? So whenever we have to carry something, we carry it on our neck and our shoulders. That is the area. So imagine if they are carrying animal skin, and this is definitely coming from the animals. So if they are carrying the hides and the skins of the animals on their bare backs, so can you say that that is why this is referred to as the Hyde-Potter's disease? It is known as Hyde-Potter's. What is Hyde-Potter? Hide is nothing but animal skin. And porters are people who carry those heavy things on their back. So these are the porters. They are the people who are carrying animal skin, and that is why they have this blackish color lesion. And this will be a classical history. That blackish color lesion will either be on the neck or the shoulder or the upper back, because that is the area where they are carrying all of those animal skins, right? So please remember cutaneous anthrax, known as the Hyde-Potter's disease. Coming to the next one, pulmonary anthrax. Why would someone have pulmonary anthrax? Pulmonary means inhaling. Pulmonary means inhaling, right? We would inhale it. Why would we inhale something? People who work in the wool industry. So wool has very thin fibers, right? So these fibers are inhaled. Wool sorters. So all the workers who sort wool, who work in the wool industry, when they inhale these fibers, it reaches the lungs and it causes pulmonary anthrax. It causes pneumonia. Please remember, this is the form of anthrax which is also an agent of bioterrorism, because inhalation definitely comes under bioterrorism. Lastly, if someone has uncooked meat, if someone is having consumption of uncooked meat, which kind of anthrax would occur in that case? Intestinal anthrax will occur. Intestine inflammation will occur. Repeating, if they carry the skin of the animals on their back, cutaneous anthrax. If they inhale it, it is known as pulmonary anthrax. If we eat animal material, it is intestinal anthrax. Which out of these results in the formation of a malignant pustule, or also known as eschar? Malignant pustule, also known as eschar. So remember, this is a cutaneous finding. Do you remember I showed you this blackish color lesion on the skin? So this blackish color lesion on the skin is known as a malignant pustule or an eschar. You will ask me that why are you calling it malignant? Does it have anything to do with cancer? No. I'm calling it malignant because look at how it's appearing. The appearance is pretty bad. It is quite invasive. It is quite dirty looking, blackish, eroded. Only because of the bad looking appearance, I call it a malignant pustule. Otherwise, it has nothing to do with cancer as such. Okay, so the three types of anthrax are pretty much sorted: the cutaneous one, the pulmonary one, and the intestinal one. Let's come to the diagnosis. When you look at it under the microscope, you can very well see that yes, these are kind of bacilli. They are long, they are bacilli. And do you see that if, for example, if this is the organism, you will say that in the center, you are seeing a whitish area. There is the area that is not picking up the stain. What is that area? That area is nothing but the spores. Did we just study that Bacillus and Clostridium are spore forming organisms? So please remember guys, when you are dealing with this, either look at the appearance, look at the kind of appearance. Either you can call it the boxcar appearance, or you can also call it the bamboo stick appearance, because it looks like this, like cars, box cars. Either you can call it box car appearance, or you can call it a bamboo stick appearance, and you see it on a gram stain. If you try to grow it on culture media, on agar, you get a medusa head. What is a medusa head? This, you won't get a picture, but definitely something that is important to know. If you grow it on an agar, you get a medusa head appearance. Number 3, if you grow it on gelatin, if you put Bacillus anthracis inside gelatin, it will give you a very important finding. See, have a look at it. This is a test tube. This test tube, what have I filled it with? This test tube has been filled with Gelatin. Do you see what has happened to gelatin? Gelatin is broken over here. It is broken a lot over here. So I can say gelatin has been liquefied. It has been broken. Where has the gelatin been liquefied more? It's maximum at the surface. Maximum gelatin is broken at the surface. And as you are going down, the amount of gelatin breakage is decreasing. So can I say Bacillus anthracis is acting maximally on the surface and least at the bottom? Why? It is breaking gelatin maximally at the surface and least at the bottom. Why? Because oxygen is present at the surface and oxygen is not present at the bottom. And is anthrax aerobic? Yes, that is the first thing we studied. Anthrax is an aerobic organism. It works in oxygen. On the surface, it's getting oxygen. It will break the gelatin. On the lower part, it's not getting oxygen, so it will not break the gelatin. And what kind of an appearance do I get out here? We get the inverted fir tree appearance. It's an opposite tree, upside down tree, inverted fir tree appearance. Number 4, what does Bacillus anthracis show us on a penicillin agar? PE for penicillin, PE for pearls. Remember, on a regular agar, if you guys remember, on a regular agar, it was showing us medusa head appearance. On a penicillin agar, it's showing us a string of pearls appearance. Next, what is the selective media? Something that we'll have to mug up. The selective media is the PLET media. And what is the antigen antibody test that we can do, which is hardly done nowadays? It's more for MCQs. The antigen antibody testing is the Ascoli's thermoprecipitant test. So Ascoli's thermoprecipitant test also happens to stand for anthrax. So let's do a recap of all 6 things. Number 1, on gram staining, it looks like boxcar or bamboo stick. On agar, it shows you medusa head appearance. On a penicillin agar, it will show us pearls, string of pearls appearance. On gelatin, it shows us inverted fir tree appearance. Selective media is PLET, and Ascoli's antigen antibody reaction is also for anthrax. Now that we've studied everything, why don't we start doing a few questions? All of the following are properties characteristic of Bacillus anthracis except motility on wet mount examination, medusa head colonies, poly-D-glutamic acid capsule, and boxcar appearance. All of the following are characteristics. So firstly, did we see the boxcar appearance? Yes. Either you can call it boxcar or you can call it the bamboo stick appearance. Does it have a poly-D-glutamic acid capsule? Anthrax? Yes, it had a poly-D-glutamic acid is what? It's nothing but protein. It's nothing but polypeptide. And does it have a polypeptide capsule? Definitely yes. Does it show you medusa head colonies? Again, yes. So what does it not show you? I have not told you that it's motile. It's not at all motile. I've not shown you any feature of motility out here. So it is a non-motile organism. This was the first question. Let's practice a few more. Moving on to the next one. Which of the following is not a cultural characteristic of Bacillus anthracis? Medusa head, string of pearls, inverted fir tree, bamboo stick. You'll say all of these are features of Bacillus anthracis. I asked you which is not a cultural feature of Bacillus anthracis. Culture. So if you see medusa head is on agar, it's on a culture plate. String of pearls is on what kind of culture plate? It's on a penicillin agar. So that is also a culture characteristic. Inverted fir tree appearance is on which agar? It's on gelatin agar. So that is also a culture characteristic. Bamboo stick appearance is not on a culture. Bamboo stick appearance is on gram staining. So that is why they had asked you which of these is not a cultural characteristic. Bamboo stick appearance is a characteristic but not a cultural one. It's a gram stain characteristic. Moving on to the next question. Which disease occurs after eating uncooked meat? I think it's very, very obvious over here because of the bias also. With uncooked meat, Bacillus anthracis, and which type? You had 3 types of anthrax: cutaneous, pulmonary, intestinal. So, but obvious, there's going to be intestinal anthrax. Intestinal anthrax is what is going to be associated with uncooked meat. Okay, having said that, let's move forward. Something that we studied probably in the previous session as well. The organism responsible for toxicity due to Chinese fried rice. The organism responsible for toxicity due to Chinese fried rice is going to be, so I told you a mnemonic, that Chinese fried rice and cereus. We are now moving on to the discussion of Bacillus cereus. Please remember, it's the food poisoning one. Where have I taught you this earlier? Where did we study that there are two organisms, Staph aureus and Bacillus cereus? Staph aureus also causes food poisoning in less than 6 hours, whereas Bacillus cereus also causes the same in less than 6 hours. So they are both causes of early food poisoning, short incubation food poisoning. When I talk about Bacillus cereus, one thing is certain, that there is food poisoning that is involved, and we keep studying it is to do with Chinese food, Chinese fried rice. So cereus for C, C for cereus, and C for Chinese. But actually, this food poisoning is of two types. One, in which the patient comes to us with vomitings, and the second food poisoning is in which the patient comes to us with diarrhea. So there are two kinds of food poisoning. Remember, the vomiting one has a Chinese fried rice and a short incubation period. It's not the diarrheal one. The diarrheal one has a lengthy incubation period of 8 to 16 hours, and it is by consumption of probably poultry and vegetables, so solid food, not just Chinese food. Remember, easier way of learning it, emetic. So when we eat food, the shorter route of the food coming out is vomiting. The longer route of the food coming out are the stools. So the shorter incubation period is for the vomiting type, and the longer incubation period is for the diarrheal type. So remember, when I say that Staph aureus and Bacillus cereus have the same incubation period, that is less than 6 hours, I hope you've understood that which kind of Bacillus cereus am I talking about. I'm talking about the emetic type. I'm talking about the emetic type. Okay, so yes, that was the question. Chinese fried rice, Bacillus cereus. Let's move on to the next. The following are true about Bacillus cereus introduced or induced diarrhea, except. So first and foremost, they're talking about Bacillus cereus, and which type of it? They're talking about the diarrheal type of it. Okay, and which of the following are true except? So is it transmitted by parenteral route? Incubation period is longer. It is caused by enterotoxins. It is usually associated with fried rice or Chinese food which is reheated. So please remember, I know that when I'm talking about Bacillus cereus, be it the emetic type or be it the diarrheal type. See, for example, Chinese food can go in both, right? Because emetic type is also Chinese food and diarrheal type is because of meat and veggies. Meat and veggies also ultimately goes in Chinese food only. So both of them are caused by Chinese food. So is it associated with fried rice or Chinese food which is reheated? Definitely yes. If it is causing food poisoning, it has to have a toxin which is going to be enterotoxin involving the intestine. So that is also true. For the diarrheal type, is the incubation period longer? Yes. If you remember correctly, for the emetic type, it is less than 6 hours, whereas for diarrheal type, it is approximately 8 to 16 hours. So definitely for the diarrheal type, it's longer. Can it be transmitted by parenteral route, means by a blood or needles? No, obviously, that is not sounding right. When it's causing food poisoning, it's not something that will go via blood or get transmitted via needles. It's definitely going to be eating. So it's going to be definitely a form of eating or oral consumption. If you want to know that what is the selective media, you don't have to know the full forms. That's the good news. I've only got you the full form because somewhere for your knowledge you can know. But MIPA and PEMBA. Remember, when we are talking about the lab diagnosis of Bacillus cereus, three words should remain in your mind. Firstly, it is motile. It can move around. That is how it's causing diarrhea also, vomiting also. It's moving around. And the two selective media are MIPA and PEMBA. As I said, knowing the full form is not important. If you wish to know, it's on the screen in front of you. But again, not important. MIPA, PEMBA, mobile. These three motile. These three words come to you. Bacillus cereus is done. I hope that's okay with everyone and we can move on forward. If you remember, all the organisms under Bacillus that I was talking about, be it Anthrax or cereus or all the others that we've spoken earlier, they are all aerobic. They need oxygen, whereas the ones that come under Clostridium are anaerobic, and that is exactly what I'm starting with next. All that come under Clostridia are anaerobes. So this means they do not need oxygen. They do not need oxygen. So what is the classification? I know right now, as I said, sometimes we see some tables in microbiology or even other subjects like a biochemistry or a pharmacology, and it's kind of overwhelming because it gives you too much of information in a text manner. Whenever you come across anything like that, the best way is to segregate it into shorter tables, make your mnemonics, visual memory, image-based mnemonics, and that's the only way of cracking such things. So let's try and decode this table also. What have they written about Clostridium? They have said that, what all do you know? Do you know Clostridium is a spore-forming organism? Yes, we know that. Clostridium will make spores. Where are the spores present? Let me show you a picture of spores. Can you see that this is an organism and then there's a round spore over here? Similarly, this is a bacteria, then there is a round spore over here. So basically they ask you the location of the spore. Look at these 4 pictures. They will tell you the location. Where do you think is the spore located over here? You'll say right at the tip. Right at the tip. Over here also, right at the tip. So can I say in these two, the spore is terminal in location. The spore is terminal. Okay, where is the spore over here? You will say exactly in the center. So one more is that the spore can be central. Next, you will say, ma'am, here also it's at the end, but not exactly at the tip, a little away from the tip. So can I say this is subterminal? What are the 3 locations, guys? Either right at the tip, terminal spore, right in the center, central spore, a little away from the tip, and that is what you'll call as a subterminal spore. Remember, the most common out of these are going to be subterminal. The most common of all, so if you say for example Clostridium perfringens, anything or the most common spore that you can have is subterminal, but for Clostridium tetani and Clostridium tertium, they have TE in them. For Clostridium tetani and Clostridium tertium, we have TE and TE for terminal. Very simple. Tetani and tertium have terminal spores. Then you'll come back and you'll say that fine, this is also terminal and this is also terminal. What's the difference? So I'll say that one of them, I'm very confident that this one is Clostridium tetani and this one is Clostridium tertium. You'll say, ma'am, both of them are terminal. How did you get to know? Because please remember, when you're writing tertium, you come across TER. Tertium gives us a tennis racket appearance. Tertium gives us a tennis racket appearance. TER for tertium, tennis racket. So tennis racket will always look something like this, a little long spore, like a badminton racket or a tennis racket. Whereas when you're talking about Clostridium tetani, this is going to be a drumstick appearance. Has everyone seen drumsticks? Drumsticks are round. If you look at the organism, the spore will be round like this, like a drumstick. So remember, when you see a round spore at the terminal, it's drumstick like tetani. And when you see this oval spore at the terminal, that is tertium, tennis racket appearance. What is common to them? TE for terminal, TE for terminal. But I hope you remember, TER is the tennis racket appearance. Coming to the next. When is the spore in the center? Means when is the spore right in the center? Whenever I put anything in the center, I'm dividing the organism into 2 parts. I'm creating a bifid. Remember, bifermentins has a central spore. So let's do a recap, guys. All the spores in all the organisms are usually subterminal, but in Clostridium tetani and in Clostridium tertium, the spores are going to be terminal and terminal. Whereas in bifermentins, dividing it into bifid, the spore is central in location. I hope the first part of the table is done, because now we move on to the next part. Clostridium species are unencapsulated and they are motile. What did I learn? Clostridium is not going to have a capsule and is no inhibition. It has no capsule and is going to move around everywhere. It has no capsule and it's going to move around everywhere, except exceptions are asked. So what do I want to tell you? When you started off your journey, NEET UG days, get back to NEET UG days, get back to 11th and 12th class, get back to those days where what were your subjects? Physics, chemistry and biology. Physics, chemistry and biology. For which exam did you take up PCB as your subjects? You took it up for an exam called Pre-Medical Entrance Test, PMT. So that's your mnemonic. You took PCB for PMT, right? So what is that? What am I trying to say? All the Clostridia are unencapsulated, but which are the ones which are capsulated? Which are the ones which have a capsule present in it? You will say Clostridium P for perfringens and Clostridium B for butyricum. So remember, PCB tells you Clostridium perfringens and Clostridium butyricum, they are capsulated, rest all of them are unencapsulated. Coming to the next, I told you all of them are motile, all of them can move here and there. But PMT, which are the ones which are non-motile, which don't have motility? Again, P for Clostridium perfringens and T for Clostridium tetani type 6. Repeating, perfringens and tetani type 6 are non-motile. So I would want to do a very quick recap. The two mnemonics that I have with me are PCB. And why did we take PCB? Because what did we want to crack? We wanted to crack. So for crack, I'll write this. We wanted to kill the exam PMT. So I took PCB because I wanted to kill PMT. But then there were some of us who were a little overconfident in life, and I would include myself also in those set of students who, apart from PCB, also took maths, who also took mathematics, who took math because they thought that why not even IIT, or why not keeping all my options open, or why not getting a better score. And all of us know that if we were inclined towards PCB, then our math was horrible, and I really don't know why all of us were so over ambitious and still took it up. And also, just in case you were one of those, please type it and let me know, so that I know that I was not the only foolish person who decided to do that when I knew that my aptitude was for PCB, and then I burdened myself with mathematics only to keep my options open. So in case you're also of the same, you've been through the same, let me know. Anyway, so we took PCB and we wanted to kill PMT. So let's see. All the Clostridia species are unencapsulated, but which is the one which is going to have a capsule? Capsule is going to be present in Clostridium perfringens and Clostridium butyricum. Okay, next, which of them did not, or which of them, or all of them motile? Definitely all of them are motile. But which are the ones which are going to be non-motile? The non-motile ones are again going to be Clostridium perfringens and Clostridium tetani type 6. That's the final summary. So I hope all of you are okay with the final summary, and we can probably attempt a question. Which Clostridium species is capsulated? As soon as you get this, remember capsulated, PCB. Capsulated which all? Perfringens, yes, capsulated. Butyricum, yes, capsulated. So what is the correct answer? The correct answer is both A and B are capsulated. So I hope finally these three tables are making sense. The spores, the capsule, the motility, because now we can move on to the next. Gas gangrene is caused by all except. This was a previous year question in the FMG exam. Gas gangrene is caused by all except. So the answer is, I think, even if you don't know gas gangrene, but you know for a fact that tetani will cause tetanus. Tetani will obviously cause tetanus and not gas gangrene. So definitely gas gangrene is caused by all the others. So let us start with this. What all am I talking about? Gas gangrene most commonly in 60% of the cases is Clostridium perfringens. Remember, in the earlier days, Clostridium perfringens was also known as Clostridium welchi. Clostridium welchi and Clostridium perfringens is the same. It causes gas gangrene. What do I mean by that? Gangrene means something is going to die, which means the muscle is going to die. There is myonecrosis that is going to happen. There is myonecrosis that is going to happen. So gas gangrene, which is going to be seen in 60% of the cases by Clostridium perfringens. Other than that, septicum and novi. Septicum and Clostridium novi, they also cause gas gangrene. Repeating, we have perfringens, then we have septicum, and then we have novi. All of these are responsible for gas gangrene. Out of these, obviously the question that you'll get will be maximally on perfringens. So let me come back to the question. Again, like I said, what all causes gas gangrene? It's caused by perfringens, it is caused by septicum, and it is caused by novi. Perfringens, septicum, novi. So tetanus does not cause it. Out of these, they will definitely ask you a question on the lab diagnosis of Clostridium perfringens, and I can see a lot of things written in front of me. And yes, that is exactly what is important. So one by one, we are going to come down to everything about Clostridium perfringens, rather than seeing it like this, I would show you one by one as separate photos. I think that will be a better thing to do, right? So first and foremost, whenever I talk about Clostridium and it reminds me of claustrophobic, the thing that comes to your mind is anaerobic. It does not need oxygen. And anything that does not need oxygen will be grown in an anaerobic culture media. What is the anaerobic culture media where there is no oxygen present? So anaerobic culture media is RCMB, Robertson's cooked meat broth. RCMB, that is Robertson's cooked meat broth, that is not having oxygen. That is for all the anaerobic organisms. Point number one. Point number two, it shows us, I'm going to now tell you many fancy names. It's going to show us target hemolysis. What is target hemolysis? Have a look at this. Target. So all of you have played that dartboard game. Of course you have, I'm sure. The archery and the dartboard game. So you know for a fact that there's a bullseye that you always have to hit. I still have one of these in my room because I think it's a game which my childhood went away, but this did not, and this is still a very famous pastime for me, and I think many of you also. So now we have magnetic ones as well and many others, which is a different discussion that we'll have some other time. But yes, I'm sure everyone's seen a dartboard and you've seen those bullseye archery boards. So they have a lot of lines around it so that you can hit in different zones, right? Similarly, the kind of blood breakage that is caused by Clostridium perfringens is target hemolysis, which basically tells you that you can see one clearing here and another clearing around it. Similarly, one clearing here and another clearing around it. So there's a double zone of hemolysis, also known as the target hemolysis, which you see with Clostridium perfringens. That is the next point. Coming to the third one, Nagler's reaction is positive. What is Nagler's reaction? Let's have a look at this picture out here. We call it a Nagler plate. What is a Nagler plate? It's basically a culture plate which is going to have egg yolk in it. It's basically a culture plate which is going to have egg yolk in it. Why have we added? Why is this whitish? Because of egg yolk. Egg yolk is something which is very rich in lecithin. Egg yolk is extremely rich in lecithin. So basically there's a lot of lecithin out here. And from the patient, I have added Clostridium perfringens. Can you see what has happened? All the area around Clostridium perfringens has become white. Why? Because please remember, Clostridium perfringens has something called alpha toxin. And do you know what is alpha toxin? Alpha toxin is lecithinase. Alpha toxin is lecithinase, right? So please remember, lecithinase will go and break the lecithin. Lecithinase will go and break the lecithin, and that is why you get an opaque appearance over here. So that is the Nagler's reaction. Repeating, Nagler's reaction is due to which toxin of Clostridium perfringens? It is because of the alpha toxin. And what is the other name for alpha toxin? Alpha toxin is also known as lecithinase. Coming to the next one, and that's the reverse camp test positive. Before I start off with this, I hope everyone remembers from our basic introduction in the previous session that there was something known as a camp test. And camp test was for an organism known as Streptococcus agalacti. It was for an organism called Streptococcus agalacti. Now I'm saying reverse camp test, which is for Clostridium perfringens. And now this is known as reverse camp test. So what do I know under reverse camp test? Vertically, I have put Clostridium perfringens. Horizontally, I have put Streptococcus agalacti. So please remember, always. Now I'll tell you the difference. We'll draw two images so that we know the difference between a camp test and we know the difference between a reverse camp test. These two is what we want to know. So what is camp test versus reverse camp test? Remember, in both of them, and I'm repeating this again, in both of them, the vertical line and a horizontal line will be there. There will be a vertical line and there will be a horizontal line. The horizontal line will always be of Streptococcus agalacti. The horizontal line will always be of Streptococcus agalacti. It's the vertical line that will vary. If the vertical line is Staphylococcus aureus, this means you are dealing with a case of, or you are performing a case of camp testing. You are trying to go in for camp testing. On the other hand, if the vertical line has something known as Clostridium perfringens, then you've done a reverse methodology and gone in for reverse camp test. So basically you realized that the horizontal line is always going to be agalacti. Agalacti is always going to be horizontal. The vertical line in camp test is Staphylococcus aureus, whereas in reverse camp test the vertical line is Clostridium perfringens. And over here the vertical line was Clostridium perfringens, so this happens to be the reverse camp test. Coming to the last one, it shows us stormy fermentation with litmus milk. Although no one will ask you this picture, but can you see that there is a litmus milk and there is some stormy bubbliness that you see at the top? Like I said, no one's going to ask you this, but with litmus milk test, stormy clot reaction is noted. Let's do a recap. We have to grow it in Robertson's cooked meat broth. Target hemolysis is seen. Nagler's reaction is going to be positive. Reverse camp test is noted, and the stormy fermentation with litmus milk is what we see out here. So I hope that's okay. Clostridium perfringens, all fancy names coming up your way. Okay, let's move on to the next one. Maybe you can answer this question now. Nagler's reaction is predominantly associated with which toxin of Clostridium perfringens? Nagler's reaction is predominantly associated with, so if you remember, Nagler's reaction was the one that was utilizing egg yolk. And if I have egg yolk, how will I break egg yolk? So you had studied that egg yolk has lecithin, and if you want to break egg yolk, you will have to use lecithinase. Now, which of these was lecithinase? Alpha toxin of Clostridium perfringens was lecithinase. Do I have any of these two in the options? Yes, I have lecithinase in the options, and that becomes my answer. Let's move on to the next question. Which of the following is incorrect about the toxin leading to the disease below? Which of the following is incorrect about the toxin leading to the disease below? So this is the disease that has been shown. First we'll identify this. It looks as if the man is smiling. This condition is known as rhizus sardonicus. This condition is referred to as rhizus sardonicus, which basically means that it looks as if, is the patient actually smiling? Well, definitely not. This is a classical case of tetanus, and obviously once if a patient has tetanus, he's definitely not smiling. But why does it look like as if he's smiling? Because all the facial muscles, all the muscles have basically contracted. So there's a contraction, there's a spasm that has occurred. This results in spasm of the muscles, and once all the muscles will undergo spasm, all the muscles of the face, they undergo spasm, it looks as if the patient is grinning or smiling. That is known as rhizus sardonicus. So if I want to answer this set of questions, I will need a little bit of theory base for myself. When I'm dealing with Clostridium tetani, it has two toxins which are responsible for everything. It has two toxins which are responsible. Number one is known as tetnolysin and the other is known as tetnospasmin. Repeating, tetnolysin, tetnospasmin. If I say that ultimately there has to be spasm of the muscles have to contract, there's going to be a muscle spasm. Which of them would ideally be the one that will cause it? You will say obviously the spasmin one will have the main role. The main role in causing the muscle spasm is going to be tetnospasmin. And how does it act? At which level does it act? It at a neuromuscular junction. At which level does it act? It acts presynaptically. Does this remind you of some very famous question that you get in forensic, where there's another poisoning that also causes the same kind of muscle spasms, but that doesn't act presynaptically, that acts postsynaptically? I hope you all remember the strychnine poisoning. Strychnine poisoning, which is again definitely a question that you can anytime get in the exam. Strychnine poisoning is something that they will tell you for postsynaptic attack. So that is going to cause postsynaptic effect, and then it is going to cause spasm of the muscles. So please remember, for tetanus it is presynaptically. Tetanus is going to be presynaptically. And who is the main one causing it? Tetnospasmin is causing it. So how do I differentiate between tetnolysin and tetnospasmin? Because both of them are heat labile. Both of them are heat labile, but their oxygen affinity varies. Remember, tetnolysin OL versus tetnospasmin. So tetnolysin is oxygen labile and tetnospasmin is oxygen stable. Repeating, tetnolysin is oxygen labile and tetnospasmin is oxygen stable. Let's come back and let's start reading it. Which of the following is incorrect? Are both of them heat labile? Definitely true. Okay, is it oxygen stable? So the toxin which is leading to spasm, I'm talking about tetnospasmin. I'm talking about tetnospasmin means is it oxygen stable? Yes, it is oxygen stable. Does it act postsynaptically? Think again. That is the false statement. I just told you that when we are dealing with a case of tetanus, it does not act postsynaptically, it acts presynaptically. And what does it do? It definitely, I think everyone knows this much of physiology, that it inhibits the release of GABA. It inhibits the release of GABA and it acts presynaptically. That is why there is a spasm of the muscles that is created. Well, okay, having said that, I suppose we can move forward and go on to the next set of questions. Botulism. Botulism causes what? Descending flaccid paralysis, descending spastic paralysis, ascending paralysis, or ascending spastic paralysis. I think in terms of the answers, botulinum or botulism causes descending flaccid paralysis. And which organism am I talking about over here? I'm talking about Clostridium botulinum. In fact, I think it's a very, very obvious kind of a question that when someone asks you that for botulinum, what is the toxin that you have to know? The toxin is the botulinum toxin. And in fact, guys, if you've read a little bit of the past literature, you would know that the most toxic substance, which is the most lethal to mankind, the most lethal and the toxic substance to mankind is Clostridium botulinum or this botulinum toxin. And what does it cause? It causes food poisoning. It causes food poisoning. Number one, it causes paralysis. Number two, repeating, what does Clostridium botulinum cause? Number one, it causes food poisoning. Number two, it causes flaccid paralysis. So remember F and F. Clostridium botulinum causes flaccid paralysis and food poisoning. Obviously, if it causes food poisoning, what kind of a toxin does it have? Intestine, food poisoning, enterotoxin. And what kind of food does it grow on? It tends to survive in canned food. And all the students who are living in foreign countries and who consume a lot of these canned foods in hostels, always remember that there is that's the reason we check for the expiry date. And even if it is within the period of consumption, even if it has not reached the expiry date, but you must have seen that they've always written on the can that if the can appears damaged, or if the can appears very swollen, or if it's become rounded and there's some gas kind of production, or they say if you see any bubbles on the food, you should not consume it. Primarily why? Because Clostridium botulinum tends to grow on canned food. So whenever you open a canned item, even if it's not reached the expiry date, but the can is looking very swollen, or if you see bubbles on the surface of the food as soon as you open it, do not consume that. Okay, so enterotoxin on the canned food causes food poisoning. Similarly, it causes flaccid paralysis. And obviously, if it causes paralysis, which toxin is it? Neurotoxin. So finally, what are the two toxins of Clostridium botulinum? One of them is going to be neurotoxin. One of them is going to be enterotoxin. The entero one will cause food poisoning and the neuro one will cause flaccid paralysis, and that is the answer to the question. It causes descending flaccid paralysis. So can I say in other words that tetanus was something that was causing spastic paralysis, it was causing spasm, and botulinum is something that is going to cause food poisoning and flaccid paralysis, F and F? Well, having done that, let's move on to the next question. A hospitalized patient developed severe watery diarrhea and dehydration following a long-term course of antibiotics. The histopathological image is shown below, and which of the following toxins are responsible for the production of this condition? So firstly, you have a case of diarrhea, so this means intestine is involved. So much of diarrhea has happened that obviously patient has become dehydrated, and this is a very important history given next. This has happened after a very long-term course of antibiotics. Remember, after long-term usage of not just cephalosporins, not just third generation cephalosporins, but any kind of antibiotics. After a long-term usage of antibiotics, what is the patient at a risk of? Patient is at a risk of Clostridium difficile infection leading to PMEC. Pseudomembranous enterocolitis, remember, leading to PMEC by Clostridium difficile. So they will always give you a long-term usage of antibiotics or cephalosporins. That is why the patient will have Clostridium difficile infection. That is when the patient will have pseudomembranous enterocolitis. How does pseudomembranous enterocolitis happen? First and foremost, the question. This happens because of two toxins called toxin A and toxin B. So remember, Clostridium difficile has two toxins. It has something called toxin A and it has toxin B, and these are the ones responsible for this condition. Further, how does the patient present? The patient is going to present with severe watery diarrhea. Why is the patient going to present with severe kind of watery diarrhea? Because let's see what has happened to the intestine. This is an intestine. Normally, you'll always draw the intestine like this, closed. What have I done over here? Instead of it being closed, I've opened it. This is the open version of the intestine. And all of you can appreciate that there is a definitive membrane, dirty, yellowish, necrotic membrane that is present on the mucosal aspect. That's the next question that you get. It is present on the mucosal aspect. So a necrotic membrane on the mucosal aspect, that is what you know for Clostridium difficile. And when you look at it under the microscope, you will say that there's a lava that has erupted. Everyone seen a volcano? We all know that in a volcano, a lot of lava is going to come out. So from the intestine, this dirty lava material is coming out. We call it a volcano-like eruption. So if you see a dirty membrane on the mucosa and you see a volcano-like eruption, like you saw over here, they gave you the characteristic volcano lava eruption. You're dealing with a case of Clostridium difficile, and toxin A and B are responsible for these. Okay, so coming to the next question. Clostridium difficile, still on the same bacteria, can be spread through all except. Clostridium difficile can be spread through all except orofecal route, direct, hand to hand, or needles. Think logically. This is basically a kind of diarrhea, intestine involvement. It's a kind of diarrhea, it's a kind of an intestine involvement. So if I think logically, how do things reach the intestine? Definitely by hand to hand contact, direct contact, orofecal contact. Reaching the intestine via needles, that is sounding a little weird, and that is what by common sense you had to rule out, that Clostridium difficile is not something that is going to spread via the parenteral route. It is not something that is going to go via the needles, and that is why this is the wrong statement over here. Finally, if you say you want to do the diagnosis, what is the media? Again, two names that you learn, but you don't need to know the full forms per se. CCFA, CCYA. So remember, for Clostridium difficile, sil has a characteristic, it has a C sound and it has an F sound. So remember that when you're talking about difficile, we'll write it in that manner. When you're talking about difficile, we have to talk about CCFA, CCYA. So difficile has CCFA and CCYA. If you want to know their full forms in front of you, most welcome to learn, but not required. CCFA, CCYA, these are the two that you have. So let's do a recap of Clostridium difficile. Number one, this is always happening after a long-term use of cephalosporins. How does it reach? It reaches by direct contact or orofecal route or hand-to-hand contact, never by needles. This organism has two toxins, toxin A and toxin B. What do they cause? They cause watery diarrhea in the patient. If I want to look at it under the microscope, I will see there is a pseudomembrane. There is a dirty membrane that is formed on the mucosal aspect. Microscopically, we see a volcano lava-like eruption, and in terms of the media, we see that there is CCFA, CCYA media that are used. Well, I guess we've done all the Clostridia. Why don't we take up a few of the pre-IQs? That will be good. All of the following organisms cause gas gangrene except. So quick test. These are PYQs of the FMG exam. All of the following organisms cause gas gangrene except. So we have studied for gas gangrene Clostridium perfringens, Clostridium septicum, Clostridium novi. Novi is not here. Welchi. Welchi and perfringens is the same thing. So which of them does not cause gas gangrene? Clostridium difficile. Clostridium difficile causes pseudomembranous enterocolitis. Next question. Necrotizing enteritis, the very, very, very important question. Necrotizing enteritis. So first and foremost, septicum we've not studied only because it's not at all important. Enteritis, when I say enteritis, difficile is sounding right. You'll say, ma'am, it causes pseudomembranous enterocolitis, but they've not written pseudomembranous enterocolitis. They've written necrotizing enterocolitis, so not difficile also. Tetani, I know, causes tetanus, that smiling face, that tetanus, rhizus sardonicus. Actually, please remember, necrotizing enteritis can be caused by Clostridium perfringens, and that is exactly what I want to add on to your knowledge, that Clostridium perfringens or Clostridium tetani not only causes necrosis of the muscle, but it can also cause necrosis in the intestine. Basically, it can also cause necrotizing enteritis. That is something that I hope you guys will definitely remember. So answer for Clostridium perfringens. Moving on to the next question. 3-year-old boy fell down and injured his leg while he was playing on the ground. After a few days, there are crepitations felt from the injured area. What could be the probable causative organism? Corynebacterium diphtheria, Pseudomonas aeruginosa, Clostridium tetani, or Clostridium welchi. So please remember, a 3-year-old boy has fallen down. As soon as I see the history of an injury and a fall, I always start thinking of tetani. Right now I think of tetani, but when I saw later, after a few days, there are crepitations felt from the injured area. Now that is something I don't see with tetani. When do we see crepitations? What are crepitations? All of those, these are, we consider them as signs of getting old. Do you sometimes move your fingers or move your neck or your back or your knee or some joint and you get that click kind of a sound? There's a click sound that comes maybe from your fingers or your neck, or when you're sitting for too long and then you stand up from your back and your knee, that those click kind of sounds are known as crepitations. But in this 3-year-old young boy, there are crepitations which are coming from those injured area. That is because gas production has happened over here. Crepitations are an indication of gas, and over here after injury they are talking about gas gangrene. So when they are talking about gas gangrene, the organism that comes to my mind is either Clostridium welchi or it is going to be Clostridium perfringens. Okay, so yes, having said this, I think we can move on to the last question of this family. Drumstick appearance. Drumstick. Think. Corynebacterium diphtheria, Clostridium tetani, Neisseria meningitidis, and Streptococcus pneumoniae. And by now we've done all, so we are going to discuss all. When we talk about the drumstick appearance, remember the answer to this question, Clostridium tetani. Because what kind of a spore does it have? TE, it has a terminal spore. So Clostridium tetani. Okay, in the previous crash course I had taught you Corynebacterium diphtheria has what kind of an appearance? It has a very classical Chinese letter or cuneiform appearance. It has a Chinese letter or cuneiform appearance. What about Neisseria meningitidis? The way you write M. We had said that we'll call it lanceolate, we'll call it lens-like. So Clostridium, Neisseria meningitidis is lanceolate, and Streptococcus pneumoniae also. This is also going to be a diplococcus with a capsule. This is also going to present in a similar manner. So over here, drumstick appearance, Clostridium tetani. Well, having said that, we do wrap up the spore forming organisms and we can definitely move on to the next family, and that is Enterobacteriaceae family. When we are talking about Enterobacteriaceae family, we have certain, I know for a fact that they are all gram-negative. We are dealing with all gram-negative organisms, but there's a certain kind of, general rule that we follow for the Enterobacteriaceae family. So please remember, when we are dealing, before I start with questions, when we are dealing with Enterobacteriaceae family, remember all of them are going to be motile, but Ella are not motile. All of them are motile, but Shigella and Klebsiella, these are immotile. They are non-motile. Repeating, all are motile, but Ella, they are immotile. Shigella, Klebsiella. All of them are catalase positive, oxidase negative. So all the organisms under this, they are catalase positive and oxidase negative, but Shigella, Ella. Remember, Shigella dysenteriae type 1. Shigella dysenteriae type 1 is catalase negative. Repeating, all are catalase positive, but Shigella, Ella, it is catalase negative. So last time repetition, all are motile, but Shigella and Klebsiella are immotile. All are catalase positive, but Shigella dysentery type 1 is catalase negative. So if I ask you this question, which of the following is a non-motile bacteria? Maybe you've not read all, or maybe you have. So if I ask you, is something that we studied, so you'll say, yes, we studied Ella are immotile, Klebsiella, Shigella, they are immotile. So the answer over here is very obvious, and this was a PYQ in the FMG exam. Shigella and Klebsiella, Ella are immotile. Coming to the next one. Catalase negative organism of the Enterobacteriaceae family. All of them are catalase positive except one organism, and that was Shigella dysentery type 1. Shigella dysentery type 1 is said to be a catalase negative organism. So I think the basic is pretty much clear, and we can move forward with the classification. How do we identify this entire Enterobacteriaceae family? This Enterobacteriaceae family is identified as lactose fermenter, non-lactose fermenter, and late lactose fermenter. Very simple. Either they ferment lactose, or they don't ferment lactose, or they ferment lactose slowly and after a while. So late lactose fermentation. LF, NLF, LLF. That is how we learn it. Lactose fermenter, non-lactose fermenter, late lactose fermenter. Remember, the only two lactose fermenters that you have over here are E. coli and Klebsiella. E. coli and Klebsiella are lactose fermenters. All the others, Salmonella, Shigella, Proteus, Yersinia, everything else of this family then automatically becomes a non-lactose fermenter. So if you remember coli and Klebsiella करेंगे. Coli and Klebsiella ferment करेंगे. That is how we've learnt it. Coli, Klebsiella करेंगे. Everyone else is not going to ferment lactose. And then we have Shigella soni. Shigella soni. Soni means keep sleeping. Wakes up very late, probably just one of us. Shigella soni keeps on sleeping, wakes up very late, so that is a late lactose fermenter. Let's repeat. Klebsiella and coli karenge ferment. They will be fermenters. Everything else, Salmonella, Shigella, Proteus, Yersinia, all Shigellas, all others, they are non-lactose fermenter except Shigella soni, because it keeps sleeping, wakes up late. That is a late lactose fermenter. So how did we identify? On what, what is the way of identifying lactose fermentation? What are the two media that we use for lactose fermentation? Number one, we have something known as a MacConkey agar. Number one media that we have is a MacConkey agar, and the number two media that we have is the CLED media. What are they telling you? In both of them, we find out lactose fermentation versus non-lactose fermentation. In CLED media also, we find out lactose fermentation versus non-lactose fermentation. But the colors are different. Over here, for lactose fermentation in MacConkey agar, you get a pink color. Whereas when we are talking about CLED media, for lactose fermentation, over here, there is a yellow color. There is a yellow color that is obtained. So repeating that when we are dealing with MacConkey agar, lactose fermentation pink color. When we are dealing with CLED media, the lactose fermentation is going to give you a yellow color. So you can see all this yellow color over here, lactose fermentation. So the next question will be that color change is happening. Color change is happening, which means there's going to be a medium, there's going to be an indicator. What is the indicator for MacConkey agar? So firstly, what all does MacConkey agar contain? It contains plant. What is plant? P for peptone, L for lactose, A for agar, N for neutral red, T for taurocolate. Let's repeat. P for peptone and agar. Every medium has peptone and agar. L for lactose, obviously, because you want to find out whether lactose is fermented or not. N for neutral red, because that is the indicator. That will change the color. That will change it to pink or yellow. That's the indicator. And T for taurocolate, because bile salts are needed. Similarly, in CLED, so if I ask you that what is the indicator, what is the color indicator that you have for MacConkey agar? And what is the color indicator that you have for CLED? So remember, for MacConkey agar, the color indicator that you will tell me will be neutral red. Whereas for CLED, can you see it's all bluish in color? Because the indicator is bromothymol blue. The indicator is bromothymol blue. These are exactly two questions that I have. What is the indicator used in MacConkey agar and what is the indicator used in CLED? And I think now you can tell me, what was the indicator in MacConkey agar? MacConkey agar was something by the mnemonic plant, right? So N for neutral red, N for neutral red, and for CLED, the blue color one. So for CLED, it is bromothymol blue. I hope these two PYQs will also be clear for all of you. Now there's no problem in solving them. So MacConkey also tells me lactose fermentation by a pink color. CLED also tells me lactose fermentation by a yellow color. But what is better? If I ask you MacConkey is better or CLED is better, and as per the latest guidelines, remember CLED is better than MacConkey. CLED is going to be better than MacConkey. So now my question to you is, why is CLED better? CLED is better, and now my question is why so? So when am I using, if I broadly ask you what are all these organisms causing? E. coli, you'll see ma'am, E. coli very famously causes urinary tract infection. Klebsiella can also cause urinary tract infection. Proteus can also cause urinary tract infection. So basically these are all media that you will use when you're dealing with a patient of UTI. So UTI can be caused by gram-negative organisms like all these you studied, E. coli, Klebsiella, Proteus. So you'll say all gram-negatives. So will gram-negatives grow on MacConkey? Will they grow on CLED? Yes, they will grow on both. So why is CLED better? Because sometimes UTI can also be caused by gram-positive organisms like Staphylococcus aureus can also cause UTI, like Candida can also cause UTI. Now the problem is that MacConkey doesn't grow them. MacConkey only gives importance to gram-negative organisms. It gives more importance to gram-negative organisms. CLED on the other hand, CLED is going to be giving importance to everyone. It will allow the gram-negative and the gram-positive organisms to grow. It will allow gram-negative and the gram-positive organisms to grow. So can I say MacConkey is very, very inhibitory. It is not letting the it's not letting the positivity come out only. It's not letting the gram-positive organisms grow. But CLED is less inhibitory. CLED, remember, why did I highlight these two alphabets? CLED is less inhibitory. It allows everyone to flourish. It allows everyone to grow. And I'll show you two questions of the previous year of AIIMS and NEET. Very important. Both of them are the same questions, only the language was different. Let's read. CLED medium is considered better than MacConkey agar for what reason? You know your reason? What does it allow? You will say first option. It differentiates lactose fermenters from non-lactose fermenters. Both of them do that. CLED also differentiates, MacConkey also differentiates. But why is CLED better? It allows everyone to grow. It allows both gram-positive and gram-negative organisms to grow. Means it allows Staph and Candida, what are they? Staph is gram-positive, Candida is gram-positive, and CLED is better because it allows everyone to grow. It is less inhibitory. It is less inhibitory. It allows everyone to grow. Next question. CLED medium is considered better than MacConkey for the following reason. What is the reason? It will allow everyone to grow. So let's read. It supports gram-positive and gram-negative. Yes, I found the reason in the first option only. It definitely supports everyone. It supports gram-positive as well as gram-negative organisms. So remember, what is better? CLED over MacConkey. Okay, having said that, coming back on the basis of this, what are the two lactose fermenters? कौन करेंगे? Ferment करेंगे, coli and Klebsiella ferment करेंगे. So you'll say, ma'am, this means that if I try to grow them on a MacConkey agar, means E. coli will also give me a pink color because it is lactose fermenter. Any lactose fermenter, E. coli will also give me a pink color. Klebsiella will also give me a pink color. How do I differentiate? So for example, you get a pink color over here. How will you tell me that whether this is E. coli or whether this is Klebsiella? Problem ho gaya? Both of them will give a pink color because please remember, Klebsiella not only gives a pink color but also gives something called, can you see it's looking very shiny and mucoid? It's pink, okay. So on the basis of pink, you will say, ma'am, pink could be E. coli also, it could be Klebsiella also. But Klebsiella is having a capsule. Klebsiella is a capsulated organism, and anything that's capsulated always gives these shiny mucoid colonies. Anything that's capsulated will always give shiny mucoid colonies. So E. coli doesn't have a capsule. E. coli doesn't have a capsule. Klebsiella has a capsule. Remember, Klebsiella has a capsule, and that is why it's going to give these kind of shiny mucoid colonies. And mucoid means if you try to pick it up, it will stretch. If I try to pick it up, it's going to stretch like this. It's going to be stringy like this. So please remember, when you are getting mucoid and stringy colonies, that is indicative that the organism has a capsule. And over here, out of E. coli and Klebsiella, the best answer for a capsule is going to be Klebsiella. I hope the differences are sorted. Coming back, I've understood how Klebsiella is going to not only give me a pink color but also a mucoid colony. Now coming back to E. coli, before I push you into lots of questions, what all does E. coli cause, guys? I hope you remember E. coli, two main things. E. coli can cause a lot of things, but the two main things that it causes are UTI and diarrhea. These are the questions, UTI and diarrhea, these are the ones that they're going to ask you in the exam. So first and foremost, let's talk about UTI. UTI, urinary tract infection. What sample will you take from the patient? When you are suspecting urinary tract infection, common sense, we'll take a urine sample from the patient. What kind of a urine sample? We have to take a clean catch, means the patient will be instructed to clean the genitalia beforehand. Clean catch, early morning preferably. Early morning, midstream urine sample. So clean catch, early morning, midstream. What do I mean by midstream? You will have to instruct the patient that when you go to pass urine early morning, divide the stream of urine into three parts. So first pass 10-20 ml of urine, don't collect that. Then collect the next 10-20 ml of urine, and after that again throw away the remaining 10-20 ml. So you don't collect the first part of urine, you don't collect the last part of urine, you are only interested in the midstream sample. That sample is what you collect. And what is the culture that you will grow it on? Which is better, MacConkey or CLED? We've studied CLED is better, CLED is being used nowadays. So you'll find out whether there's E. coli, whether there's Klebsiella, you'll find out. What is the criteria for diagnosis of UTI? For the diagnosis of UTI, we use something known as the CAS criteria. What is CAS criteria? CAS criteria says that you will give a diagnosis of UTI when the bacteria are more than 10 to the power 5. 1, 2, 3, 4, 5. When the bacteria are more than 10 to the power 5, that is when you are going to give a diagnosis. Means 1 lakh colony forming units per ml. When there is more than 10 to the power 5. Why have this criteria been kept? Why not 10 to the power 4 or 10 to the power 3, 2, 1? Because are bacteria only present in case of UTI? No. Aren't bacteria normally also present? Don't we have bacteria in the urinary tract which act as commensals? So maybe there is E. coli as a commensal. 10 to the power 2 are seen. Will you give it as a case of UTI? No. If you want to call it a disease, if you want to call it pathogenic and disease, you must cross 10 to the power 5 colony forming units, CFU. However, there are some exceptions to the CAS criteria. When do we consider a count less than 10 to the power 5 also significant? Remember, you will consider it significant in case of a SPA. What is a SPA? S means suprapubic aspiration. Means what? Has the urine come out via the normal route? Has it come out via the urethra, via the urinary tract? No. You have directly punctured the bladder and taken the urine. You have directly punctured the bladder, suprapubic aspiration. Are you going to, so if urine would have come from the direct route and urine would have come through the urethra, then the commensals would have been there. then you would have had to wait for the 10 to the power 5 cutoff to call it pathogenic. But when you've directly taken the sample from the bladder, then the commensals are not there, then even 1 or 2 bacteria are significant, then even a 10 to the power 2, 10 to the power 3 is going to be significant. So in case of suprapubic aspiration, don't consider this cutoff. Next, in gram-positive organisms, like staph and candida, they are not commensals of the urinary tract. They are not commensals. So even if they have a count of 10 to the power 2, 3, you consider them as significant. Similarly, A for antibiotics and diuretics. Many a times in our country, patient will say that, from a local chemist, I took some antibiotics, then I have come to you for the sample. I've been taking antibiotics since 5 days. After that, I'm feeling that I'm not showing much of improvement. So now I've come to you to give my urine sample. So antibiotic will anyway decrease the bacterial load. So you won't wait for 10 to the power 5. Below that also you will give the diagnosis. Same way patient says diuretic. If the patient is on diuretic, this means the urine is already diluted. The urine is coming to you as a diluted sample. Then again you don't wait for 10 to the power 5 cutoff. So repeating, what is the significance, or finally what is going to be the mnemonic for the CAS criteria exceptions? Firstly, CAS criteria says that you call it significant UTI over 10 to the power 5. However, if we have suprapubic aspiration, gram-positive organisms like staph aureus and candida, or any antibiotic diuretic therapy, we don't follow the CAS criteria. This is when E. coli causes UTI. What about E. coli causing diarrhea? Now that is going to be very, very tough. Obviously, if I've said it's very, very tough, means I'm trying to just scare you because it's very, very tough in the textbooks, means we are going to simplify it. So first let's simplify it and then we'll move ahead with lots of questions, right? These are all the diarrhea strains that you have for E. coli, all the diarrhea strains. And can you see what is the difference? EPEC, so P alphabet, then changes to T, so ETEC, changes to EIEC, HEHEC, and EAEC. Remember, these are all the different strains of E. coli that can cause diarrhea. What do I have to know? So E will always stand for entero. Okay, so it's going to be entero something E. coli. For example, I say entero something E. coli, entero something E. coli, entero something E. coli. So over here, entero pathogenic E. coli. What does enteropathogenic E. coli cause? Enteropathogenic E. coli causes P for pathogenic, P for pediatric. P for pathogenic, P for pediatric, it causes infantile diarrhea. Enteropathogenic E. coli causes P for pathogenic, P for pediatric, infantile diarrhea. ETEC, enterotoxigenic E. coli, T for toxigenic, T for traveler's diarrhea. Easy to learn. Enterotoxigenic E. coli causes traveler's diarrhea. Enteroinvasive E. coli, invasion, something that is going in the cells. It's not going only till the intestine, it's going inside the intestine, inside the cells. Anything that will invade will cause blood to come out. Blood in the stools, what is that condition known as? Blood in the stools is known as dysentery. So because it is invading, it causes bleeding in the stools, that is dysentery. Enterohemorrhagic E. coli, so it will cause some bleeding, it will cause some hemorrhage, and it causes HUS. What is HUS? For those who are unaware, HUS stands for hemolytic uremic syndrome. HUS stands for hemolytic uremic syndrome. Hemolytic means blood is going to break. Blood is going to break. Uremic means kidney is going to get affected. Kidney is going to get affected. For those who don't know, please remember that this hemolytic uremic syndrome has a very classical triad. It has a very, very classical triad that you have to follow in the exam. And what is that triad? We call it the rat triad. We call it the rat triad. Means when you're dealing with hemolytic uremic syndrome, R stands for renal insufficiency. There is kidney involvement that occurs. A stands for anemia, because I think you know hemolytic uremic. So which kind of anemia? Hemolytic anemia. And also there is something that is known as thrombocytopenia. There is also known as thrombocytopenia. There is also thrombus formation that occurs. Clot formation occurs, thrombocytopenia can occur. So remember RAT, renal insufficiency, anemia, and thrombus and thrombocytopenia. Hemolytic uremic syndrome caused by hemolytic, so hemorrhagic E. coli, enterohemorrhagic E. coli. The only one for which you have to learn the strain. What strain of EHEC causes hemolytic uremic syndrome? O157H7. O157H7 causes hemolytic uremic syndrome, enterohemorrhagic E. coli. Lastly, enteroaggregative E. coli. Now, guys, what kind of diarrhea? Persistent diarrhea. How do I learn that? Enteroaggregative. You and I, we are together in this crash course, microbiology crash course. We really don't like the subject. Let's be very, very honest about it, because the subject has a lot of cramming up and too much of mugging up. So we don't like it. We keep forgetting it. It's volatile. So what have we decided? We've decided we'll do a crash course. All of us will sit down together. When all of us sit down together, united we stand, we mean we are going to make a persistent impact. If we decide cumulatively, if we decide collectively that we are going to study and we are going to crack this subject, we will definitely do that, right? So when all of us get together, we have more impact. So similarly, when all these aggregate together, when there is enteroaggregative E. coli, they have a longer time of diarrhea, persistent diarrhea. And one more thing, when you try to grow it on Hep2, what is Hep2? Hep2 is a kind of a cell line. Hep2 is a kind of a cell line. So please remember, on Hep2 cell lines, it gives a stacked brick appearance. Not any of these, only enteroaggregative E. coli gives a stacked brick appearance. Stacked brick means something like bricks. Again, can I learn it like aggregated bricks? Bricks which have been kept together, bricks which have been aggregated, so everything will make sense now. Enteroaggregative E. coli causes aggregated brick appearance or stacked brick appearance, and once we aggregate, long term, means persistent diarrhea. Let's do a very, very rapid revision of all these mnemonics that we've just studied, guys. Firstly, enteropathogenic E. coli, P for pathogenic, P for pediatric, infantile diarrhea. Enterotoxigenic E. coli means T for T, traveler's diarrhea. Enteroinvasive, invasion will cause bleeding in the stools, dysentery. Enterohemorrhagic, hemolytic uremic syndrome, O157H7. Enteroaggregative, long-term, persistent diarrhea, aggregated bricks, stacked brick appearance on Hep2 cell lines. These are all the diarrhea strains. Repeating, enteropathogenic, enterotoxigenic, enteroinvasive E. coli, enterohemorrhagic E. coli, and enteroaggregative E. coli. All these are important E. coli strains which cause diarrhea. Well, having said that, I think we are ready for some questions. Which organism causes HUS, hemolytic uremic syndrome? We just studied, okay, when I read the options, I think there's no confusion at all. Answer to the question E. coli, but which kind of E. coli? Hemolytic uremic syndrome, HUS, is caused by enterohemorrhagic E. coli. And did I teach you any strain also? O157H7 strain of enterohemorrhagic E. coli causes hemolytic uremic syndrome. Next, again, indirect way of asking you. Hemolytic uremic syndrome, short forms given. Now we know it. Hemolytic uremic syndrome is caused by EIEC, EPEC, ETEC, or EHEC. So enterohemorrhagic E. coli. Coming to question 3. Traveler's diarrhea is caused by traveler's diarrhea. IEC, PEC, TEC, or HEC. T for T. Traveler's diarrhea is caused by enterotoxigenic E. coli. See how the questions are becoming so smooth and so simple to follow. Next question. All of these are PYQs of the FMG exam. Antimicrobials are given in which type of diarrhea? Antimicrobials or antibiotics are given in which kind of diarrhea? So do you give it in diarrhea caused by osmosis or secretory diarrhea? Or do you give it in something like a viral diarrhea, that is rotavirus? Or you give it in travelers. Travelers diarrhea is which E. coli? Enterotoxigenic E. coli, basically bacteria. So in which of them do you give antimicrobials? Which kind of diarrhea? Obviously we give antimicrobials and antibiotics when we are dealing with bacterial etiologies, not for viruses, not for osmotic or secretory kind of diarrhea. Antimicrobials are obviously given for bacterial, travelers, ETEC type of diarrhea. Next, which of the following shows the stacked brick appearance on cell lines? Stacked brick appearance. I also called it aggregated brick appearance. So which of them? Remember entero-aggregative E. coli. Entero-aggregative E. coli. So that is going to show you the stacked brick appearance. Let's move forward. Okay, let's take up the next question, guys. 5-year-old girl attended a birthday party at a local fast food restaurant. After 48 hours, she developed cramping abdominal pain and a low-grade fever and had 5 episodes of loose bloody stools. She is taken to the emergency room next morning as diarrhea continued and she looked pale. So overall, right now it looks like a food poisoning. Fast food restaurant with fever, with pain and loose bloody stools are there. And because her diarrhea is continuing, she started looking very, very pale. She's taken to the emergency room. On examination, she is hypotensive with tachycardia. So obviously so much of blood loss has happened, so much of water loss has happened. So obviously she is becoming hypotensive with tachycardia and her blood reports have shown hemoglobin 8. Is she coming across as anemic? Is she coming across as anemic? Yes. Then they found out that there is thrombocytopenia. Okay. So they've also found out that her platelet count is low. There is thrombocytopenia and there is evidence of hemolysis. So which kind of anemia is there? Hemolytic anemia is there. Is this sounding like some kind of a triad? When I look at the options also, did we study something called RAT? Only this part was missing in the question. The renal involvement is not mentioned. Other than that, hemolytic anemia is mentioned, thrombocytopenia is mentioned. Are we indirectly targeting a case of hemolytic uremic syndrome? See, diarrhea causing organism following which there is hemolytic uremic syndrome, enterohemorrhagic E. coli. And enterohemorrhagic E. coli, which strain? It is O157H7. That is how a question of EHEC will come in the paper. Coming to the next question. The blood of a patient is suspected to have pyogenic live abscess was sent for culture. So there's a patient who has a pyogenic, it would be a liver abscess actually. Pyogenic liver abscess is sent for culture. That makes more sense, right? So when we are talking about liver abscesses and conditions, two things. Either you're dealing with a pyogenic liver abscess or you're dealing with an amoebic liver abscess. So amoebic liver abscess means parasite, entamoeba, parasite. Here when they say pyogenic liver abscess, bacteria. The colony morphology shows large mucoid colonies. When I say large mucoid colonies, mucoid is something which I have studied is organism that contains a capsule, and out of these the organism that contains a capsule is Klebsiella pneumoniae. The organism with a capsule is going to be Klebsiella pneumoniae. So this mucoid word and Klebsiella will always go hand in hand. Coming to the next question. PPA test is used for the diagnosis of. PPA test is used for the diagnosis of. So please remember P for P, PPA test is used for the diagnosis of Proteus, and that is the next organism that I am going to teach you. So first let me teach you and then I'll come back to this. What is Proteus? Everything about Proteus has been written over here. So P for, there are two P's that you have to know. So first, it has something known as the PPA test or the PPA reaction positive. You don't have to know the name of the entire reaction, but that is phenyl pyruvic acid. If you wish to know the name, remember Proteus is phenyl pyruvic acid going to be positive. Another P for Dine's phenomenon. What is Dine's phenomenon? Let me tell you that. So before I move on, can you see U and S? U for what enzyme does it produce? It is urease positive. And what motility does it show? It shows the swarming motility. It shows the swarming motility and urease positive. Do you guys know what is swarming? This is swarming, that if you're dealing with the case of blood agar, can you see these concentric? So bacteria grows, then another circle of motility, another circle of motility. So this is referred to as The swarming motility. When you're dealing with microbiology, what are all the organisms that show you swarming motility? PVCs. PVCs show us swarming motility. What is all of that? Remember, P for Proteus, VP. VP means Vibrio parahemolyticus. That way, as you'll recall, it's not Vibrio cholera, it's Vibrio parahemolyticus. C for Clostridium tetani and S for Serratia. Let's do a recap. We have P for Proteus, VP, so that is Vibrio parahemolyticus, Clostridium tetani and Serraceous. They show you the swarming motility. So I've understood the meaning of swarming motility. I've understood that it produces urease. I've understood it has a PPA reaction positive. It is something called Dine's phenomena. What is Dine's phenomena? It's the story of you meeting your best friend versus you meeting your enemy. Before I get on to it, very interesting. So whenever, for example, in the lockdown, you were not able to meet your best friend for 2 years, for example. Now after 2 years, when you meet your best friend means someone you vibe with, someone you relate to, someone whom you are very fond of, someone who's just like you for that matter. So when you meet your best friend after 2 years, you're going to just run towards him or her and hug her because you're meeting him or her after a lockdown after 2 years. So if you're same and if you vibe together, you'll hug each other. What if you meet your enemy after 2 years? You're going to maintain a distance, right? Because you're not same kind of people. You don't gel together. You don't vibe together. You don't like each other. So you won't hug each other. You'll stay away. You'll maintain a distance. Same happens with Proteus. Please remember, same happens with Proteus. So for example, this is a blood agar that I have over here. Over here, I put one Proteus, strain number 1. This is also a Proteus. So from patient 1 also I have taken Proteus. From patient 2 also I have taken Proteus. Now, if they are the same, if they are the same strains, means they are best friends, what will they do? This one will start swarming from here. This one will start swarming from here, and ultimately they'll all fuse into each other because best friends are supposed to gel. Best friends are supposed to hug each other, right? However, if from patient 1 and if from patient 2, they are different strains. If they are different strains, you'll say that is exactly what has happened here. Can you see this has stopped swarming over here? This has stopped swarming over here and this one has stopped swarming over here. There is a line present. I'll show you one more picture. See, very classical. This was Proteus number 1. This was Proteus number 2. It started swarming but it stopped over here. This started swarming but it stopped over here. So if you see that there is somewhere a line of demarcation present, means distance has been maintained. Line of demarcation is present and distance has been maintained. Are they same or are they different? Are they best friends or are they enemies? If there is a distance maintained, you will say they are enemies. They are different strains of Proteus that you are dealing with. They are different strains. So let me make you ask you one question. The phenomenon shown below is indicative of. So can you all see the phenomenon shown below is the Dine's phenomenon for sure, right? This is the Dine's phenomenon. And do we also know that I can see a line in between? So they are different strains. So if I ask you what is the answer, are they same strains of Proteus, different strains of Proteus, different strains of parahemolyticus or Clostridium? I know this is Proteus, and if distance is present, they are enemies. They are different people. So what is the answer in that case? These are different strains of Proteus. So repeating once again, guys, repeating once again, P for Proteus, P for PPA test positive, P for Dine's phenomena positive, O for they result in a fishy odor. This organism has a fishy odor. It is urease enzyme positive and it shows us swarming motility. What are all the other organisms that show us a swarming motility? Swarming motility is also shown by PVCs, which means we have Proteus, Vibrio parahemolyticus, Clostridium tetani and Serratia. All of these belong to the PVCs that you have to know, right? All of them show swarming motility. Well, I guess we can take a break on that note, and obviously the family that we are dealing with, that is the Enterobacteriaceae family, still has a really long way to go. So we will be taking that up in the next part of the microbiology crash course. So we've covered E. coli, Klebsiella. We've also covered Proteus. We would be covering Salmonella, Shigella. Along with that, we'll also be taking up Pseudomonas, Rickettsia, Chlamydia, and all the tiny tiny bacteria that we are left with. So also Vibrio, one very important family. So these are the bacteria that are left, which we'll be taking up in a slightly lengthy session that we'll have tomorrow. But yes, tomorrow we would be wrapping up, or in the next session we would be wrapping up the final bacteriology portion, so that we can move on to virology and parasitology after that. Out of all, bacteriology always takes a little more time. It's a little more time consuming because there are so many bacteria. The problem is that I can also teach you all the bacteria in one day in a single session, but then it becomes a big mess in the mind. So it's always better to break it up into smaller portions and study bacteriology for a longer retention. Well guys, as I said, the PDF of this session, I would also be sharing it over Telegram and other social media platforms. All the links to the social media platforms are already given in the description below, so you can definitely join in and download the PDFs from those. Thank you so much for joining in, and I'll sign off for today for this session, and I'll be meeting you in the next session with all the other bacteria important as a crash course. Thank you so much guys. Study well. All the very best.